Okay, so good afternoon, everyone, and welcome to today's webinar hosted by the University of Bath Institute for Policy Research and the Centre for Death and Society. Thank you for joining us online, and I'm delighted to be joined by John Troyer today. Dr. John Troyer is the Director of the Centre for Death and Society at the University of Bath. He's a co-founder of the Death Reference Desk website, the Future Cemetery Project, and a frequent commentator for the BBC. His new book, Technologies of the Human Corpse, was published by the MIT Press in May 2020, and he grew up in the American funeral industry. Today, he will be discussing the AIDS pandemic and COVID-19. The HIV AIDS pandemic that began in the latter part of the 20th century set the stage for many of the current COVID-19 social policy dynamics and general public expectations. In thinking through the oft-cited age of COVID-19, it's important to continue rethinking the AIDS pandemic and what it teaches us today. How might public policy agendas reconcile with the grief and rage of families watching loved ones die due to coronavirus complications? And how does the fact that the AIDS pandemic is still happening impact what the future of COVID-19 might become? So before we begin, there's just a couple of housekeeping notes I'd like to share with you all. Please note that your cameras and microphones will remain switched off. If you have a question, please submit it via the chat function, and we'll aim to respond to all questions towards the end of the session. The session is also being recorded, so filming and photography is taking place. Subject to no technical difficulties, the session will be available online as a podcast and a video at a later date. So thank you all again for joining us, and I'll now kick off today's discussion by handing over to John.
All right, Sarah, thank you very much. I appreciate introducing me. Welcome, everyone. I'd like to thank everyone for coming today and for attending this talk, and thank the IPR for this invitation to speak today about both, I'm going to grab my watch so I'm staying on time, both about COVID-19 and the HIV AIDS epidemic. So like Sarah said, my name is John Troyer. I'm the director of the Center for Death and Society. And when I was first speaking with Amy and Sophie at the IPR about sort of a joint new project with CDAS on COVID-19 themes, one of the areas I was interested in and remain interested in was sort of like the ongoing legacy of the HIV/AIDS epidemic and pandemic, in part because there is research I do in my own work on the AIDS epidemic and its relationship to death and dying, and also the dead body, but also too because of different, I would say, resonances, not so much direct similarities, and we'll get into this idea of similarities in just a second, between HIV/AIDS and COVID-19. So again, thank you for coming. I'm more than happy to field questions at any point toward the end, pardon me, around any questions around both what I'm talking about today, but also just COVID-19 questions in general, and the impact around death and dying if people have them, as we've seen them. So the Center for Death and Society was founded in 2005 at the University of Bath. Many of you will probably know about CDAS, but CDAS was launched in the Department of Social and Policy Sciences and is an interdisciplinary study center working on all things around death, dying, the dead body. I joined the university in CDAS in 2008 and have been director since 2015. And CDAS remains really one of the world's only interdisciplinary study centers around these topics. And we have a annual list of events. I think many of these events this coming year will be a mix of both online and, if you will, physical space seminars, although we're still trying to figure that out. And a lot of the work will be around COVID-19 and experiences that our friends and colleagues have had around that. We do have a monthly newsletter through that comes out free each month. So if you go to bath.ac.uk CDAS, you can email in a request to be on the newsletter. So I just quickly wanted to say that I am originally from the US. I'm from the state of Wisconsin in the north, and I'll show you where that is. So this was a data project that was done a couple years ago. I won't spend too much time on it. A few years ago, looking at online obituaries that show the most common expression used to say that someone has died It was a way of seeing how different states say it. So Wisconsin is up in the middle north, was called home, is the state of Wisconsin. Many of you'll see it. I don't have the luxury of a laser pointer now. I point these things out, but I'm actually in Wisconsin right now. I'm in my parents' house. I've been here since March. I came here to help my mother with some medical appointments. She's fine. Also, my father had some medical issues earlier in the year, so I was here to help them both with that. And as a result of COVID-19, have been stuck here in Wisconsin since. That has presented its own interesting challenges. However, it has also been interesting to be a carer for my parents, although they're both fine. Everything worked out during the time. Anyway, so I'm in Wisconsin and happy to field any questions about what's going on in America right now. When I answer your questions. My own work, I just wanted to say very quickly, has always been more around the dead body and technology. And so a lot of the work I started around dead body technology is really comes out of the 19th century. In 19th century interests in embalming, but also preservation of the dead through processes like embalming, but also photography. And this was an important, for my own research, embalming advertisement using a photographed dead body from the early 20th century for Bisga embalming fluid. I'm not going to be talking about that so much today, but this idea of preserving the dead and what the dead could look like or should look like in the American context, but in an American context that begins to spread out around the world, that becomes relevant in the 1980s when we talk about what the HIV AIDS Corpse presents as a challenge to the funeral industry in America, but then more globally. So in May of this year, I had a book that came out, and MIT Press would be very upset if I didn't mention my new book, Technologies of the Human Corpse. And in that book, in chapter 3 in particular, I take a look at what I refer to as the HIV AIDS Corpse, in part because that corpse represented a real transitional moment in both concepts of death and dying, but also just a lot of social policies around caring for the dead, or what health policy, what basic industrial or occupational policy should be for caring for the dead as a result of the HIV virus. And the HIV virus then represents a sort of a crucial turning point in how disease becomes something that is negotiated in the latter part of the 20th century in terms of technologies for dealing with the dead. And by dealing with the dead, I mean how they're prepared, what happens, embalming, but also presentations, but also just things like infection. This is we'll see this image again. This was a key publication in 1992 by the National Funeral Directors Association in America. It's sort of the sibling of in the UK, we have the National Association of Funeral Directors. But here in the States, the National Funeral Directors Association was trying to figure out, was struggling, was in the middle of a huge rush to come up with guidelines and protocols for dealing with individuals who had died from, or to create funerals or to help families for individuals who had died from complications from HIV/AIDS. And so you find these publications in the early 90s, in which late 80s, early 90s, in which there's a real struggle with the available data and what is known and what is unknown, but also to what can be done to create something like a funeral as it had been understood before the moment of AIDS. And this is something that has come up quite a bit in the context of the coronavirus itself. I'll come back to the director image later on in just a little bit, because it then creates I think a further series of ripples for what we're talking about today. In the context of AIDS, it's always important to remember that as AIDS becomes a global epidemic and then pandemic, and a pandemic that is with us today, if you're a person of a certain age, like I am, and of a certain generation, then the impact of AIDS and this idea of there being something like a World AIDS Day, which starts in the mid-90s, the idea of the red ribbon, it becomes a real anchor point in trying to understand the social and cultural experiences of disease. Now, these are different across what I would say are the developing and the developed world, or the global north and the global south, however we want to think about these things. But nonetheless, there's this idea that there is this flashpoint of AIDS that creates a whole new kind of cultural dynamics that have in many ways become part of the history of disease, I would say, within the West. But in large part, many of them have been forgotten outside of the people who are themselves living with HIV or working in the field itself. But nonetheless, there was a real push for the recognition of how an entire global dynamic of cultural interaction was changed by the disease itself. So I want to talk just about death today, if we can think about death today, in the context of where I think a lot of the discourse we have around death today comes from, which is both a product of a lot of HIV/AIDS work, but also I think a product of a lot of work before the 1980s and the 1970s, which I think is a key decade to set the stage for how we can talk about things like disease or HIV/AIDS today. So the 1970s, certainly in the West, but this is more specific to America, and I want to be clear about that, really starts with, the 1970s. You have President Richard Nixon declaring the war on cancer. By the end of the decade, by 1979, spilling over to 1980, you have President Jimmy Carter creating a presidential commission to try and come up with a determination or a definition of death. A lot of this comes from the development of life support technology and how life support technology is radically reorganizing what we think of as dead, or what the definition of death could be. For those of you who work in bioethics, of which my own background merges into bioethics, the presidential commission that Jimmy Carter creates does become the President's Commission on Bioethics for many presidents. Interestingly enough, just as a sort of factoid for US politics today, President Donald Trump has yet to name a presidential bioethics commission. And there's some discussion about whether or not he would ever do that. But I think that in the 70s, we begin to see this merger of a whole opening up of the question of like, well, what is dead? When does death happen? What can death be? It's also when we begin to see this movement towards a radical life extension, where this idea that we humans have now mastered technology and science and medicine in such a way that we can live for almost forever if we want to. And Bob Ettinger publishes a very important book in the 60s in this regard around the idea of cryonics through the prospect of immortality. He creates his Cryonics Institute, this idea you can cryogenically preserve yourself and then be brought back at a future point. No one knows when that future point will be, but through technology, we will solve the problem. And I think that this idea of technology solving the problem becomes a crucial way of thinking for humans interacting with disease, but also with novel viruses such as the coronavirus. And this is an idea of this is a different facility in the southwest of America called Alcor. This is the idea of what the preserved human body would look like. There's also another important book that comes up in the 70s, and I want to flag this up in part because I think Lynn Laughlin's book is a great way of thinking through discourse and ideas, but also language that helps shapes policy around death and dying. It's her book, The Craft of Dying, The Modern Face of Death, comes out in '78. MIT Press I was able to convince them to reissue it, and I highly recommend getting it. It's in the library at the University of Bath, but also it's a good book to have on hand. Just for the record, to be clear about it, I did write a new introduction, but there's an excellent epilogue by R.F. Francis, who was a graduate student, one of R.F. Francis's last graduate students in California, who worked with Lynn Laughlin. But Laughlin, I think in the 1970s, identifies death as a social movement, and that creates a new understanding of how death itself can become part of social politics, and then how that politics then plays into policy. And so what Lynn Laughlin will describe the 1970s as creating is something she'll say is a happy death movement. And a happy death movement is not a pejorative. What she'll describe this as activists who want to encourage discussion around death and dying, and that these discussions are very important to encourage conversations around death. And that this is the idea of the happy warrior. It's also a series of movements come out of this of this, that many of which are with us today. This idea of a natural death movement where you can choose to not seek further treatment and die. Death awareness movements, death acceptance movements, death with dignity movements. A lot of what we would regard as being assisted dying groups really begin to emerge in this moment. But it's a moment of politics in which you have a sort of a collective social movement that is in many ways modeled after the women's movement and the early environmental movement. And these movements, in all their own ways, begin to see death as a social phenomena that needs to be rethought in terms of its policy and practice, and how death can be made fairer, how death can be made more autonomous in terms of decision making. And throughout the 1970s, you see a deluge of new materials that are published. So you have books and films and newsletters. It's a large outpouring of materials, many of which have kind of been forgotten about, in large part because a lot of it hasn't been digitized, or it's just not in a digital format. But nonetheless, the material is there. You begin to see the creation of academic courses at universities, courses around the psychology of death, the sociology of death. Psychology of death, sociology of death are both areas the University of Bath teaches today still. But you begin to see a real groundswell around interest in these topics. And importantly, as building on from the 1960s, and this is where the UK becomes crucial, you begin to see the creation and the understanding that there need to be things like dying places, or around the idea of home death or hospices. And this comes from Cicely Saunders' work at St. Christopher's in London in '64. She begins to create this idea. So by the 1970s, you begin to see the understanding that hospices are important as a radical, in some ways politically radical space where people will go to die. So the hospice becomes a phenomenon to itself. And in 1970-71, you begin to see the first hospices established, for example, in North America, in the US, particularly on the East Coast and on the West Coast. And how this is done, Laughlin will talk about, is through talking about death, what she calls death talk. And that in the Happy Death movement, the emphasis is really placed on people discussing death, wanting to work around death, but then public conversations around death informing how policymakers are making decisions around what should be done to create, if you will, a better way to die. And a lot of those models are still with us today in terms of public advocacy, public action groups, special interest groups, however you want to position it, but nonetheless, there's this idea that there needs to be more discussion around death. And that the Happy Death movement will I think, quite clearly manifest in lots of different directions. But then one of the questions that comes up as a result of it, so what happened? Where did this idea of the Happy Death movement go, or how did it change? I would say it's still with us today, but I think that there's a crucial follow-on event then from the 1970s, and that of course brings us back to AIDS. So through the 1970s, you have both this political interest, you have this political discussion around death as a both social activist point, but also as a policy agenda item. So for example, the Natural Death Act in California is passed. The Natural Death Act in 1976 was brought forward to give people the legal right to resist treatment so that they could die a more natural death. But AIDS represents a flashpoint in which suddenly you had a new disease, largely impacting initially gay men and also intravenous drug users. And so you had a cultural politics that was built around trying to understand what was going to happen in populations that were already politically on the sidelines, or certainly were not in the mainstream population of the US or around the world for that matter, but that the politics of it was such that because of the way that the virus or the epidemic initially was working, it required simply a new kind of activism. And that activism around AIDS, but also that the the push to inform or to change policy comes in large part from the activities of the 1970s. So my argument is that in the 1970s, you create a sort of a political social action platform that then gets moved into the 1980s, and it doesn't fit. It's not a perfect fit, but it works well in trying to raise awareness around something like AIDS. So we come back to the AIDS epidemic in the funeral industry, and if you can say anything about epidemics in general, pandemics in general, is that you know, there will be differences in how the viruses affect the body, but if it's a novel virus in particular, that means people will die. And indeed, I was interviewed early on about the coronavirus, and reporters trying to ask me, you know, well, what do you think is going to happen? How's this all going to play out? And I said, you know, I don't know. Honestly, I don't know what's going to happen, but I can tell you this, that because this is a novel virus, I can tell you that people will die because there's just not the immunity to the virus itself. And as a result, there are going to be, you know, changes to how we think about what happens with the dead body. And in many ways, that's exactly what happened. So when we think about the HIV and we think about the coronavirus, a couple of quick things about that. They're different viruses, and I think that there's a danger in trying to too closely compare the periods we're going through, or certainly virologically compare the two things. So this is the HIV virus. That's the coronavirus. And as viruses, they are, as you would guess from these depictions of them, somewhat similar. But Robert Gallo, who was one of the early HIV virus researchers from the back 1980s, he had a great quote about this in the New York Times, where he said, you know, HIV and the coronavirus, they're similar, but it's sort of like comparing a squirrel and a rabbit. And I think that's fair, because I think that the viruses themselves have interacted with the bodies differently. The way that they're transmitted is clearly different. Interestingly enough, I will say that this has been forgotten about, that in the early 90s, there was real concern that shows up in the literature around what happens if HIV becomes airborne. And there was, you know, a lot of thinking around this idea that how problematic that itself would, you know, become. But what comes out of I think the AIDS epidemic itself, and through different you know, groups trying to address different things, but particularly in the gay community, is a world of activism that is in many ways represented first through healthcare. And one of the first groups to pop up around this was in New York City, the Gay Men's Health Crisis, or GMHC, which still goes, but was really trying to pioneer home care or healthcare or home-based healthcare, particularly end-of-life care for individuals who were dying from HIV. But then also a follow-on group, which was ACT UP, which was the AIDS Coalition to Unleash Power, which was a much more aggressive direct action, social action group to raise awareness around HIV/AIDS, but also the try to raise awareness around medications, treatments, whatever might happen around HIV, and trying to help create a Food and Drug Administration, for example, in the States, that was working more quickly to develop treatments. A lot of this comes out of social activism that within the sort of the LGBTQ community that is trying to address longstanding wrongs of negligence over care, but AIDS really brought that to the fore. And so there's what you get is you get through this idea, and this is where the idea of rage came from that I was talking about in the abstract of the talk, is that there's this idea that there needs to be a direct political attention drawn to the disease, because the social policy people, particularly elected representatives, we're not addressing the disease. And it goes without saying that Ronald Reagan, George H.W. Bush, as well as Margaret Thatcher, for that matter, AIDS was just something they didn't talk about, and that within the political arena of where, you know, politics meets policy, it was simply determined that individuals were dying at such a rate that it became impossible to not say anything. There's a really good film on this. I wanted to put this in because there's a narrative film. It's a fiction film, 120 BPM, which is a French film, and came out a couple years ago, which is a film about the Paris ACT UP movements in the early 1990s. I was a little bit leery about going to see it when I saw it, but actually it's a good film if anyone's looking for a film that in narrative film, non-documentary. There's a number of documentaries, particularly How to Survive a Plague, that are very good about this period of time too. But this was a film that I think captured a lot of the politics around what was going on with ACT UP and its ideas of trying to change the pharmaceutical companies, but also just general policies around drug treatments. One of the figures that looms large in all this, and I'm going to bring him in, is Larry Kramer, in part because he recently died. So Larry Kramer helped co-found the Gay Men's Health Crisis and then co-found ACT UP, and was in some ways has become kind of a figurehead for these organizations, although I think that's a bit unfair, particularly with ACT UP, which was a really diverse organization of lots of different people from lots of different backgrounds. But nonetheless, it was Larry Kramer who, love him and hate him, who really pushed people. This is a photo from a very famous speech of his, where he was just kept repeating the word plague. That was, as he described, AIDS, but also too, and this is where the U.S. politics in this becomes interesting in terms of medical treatment and sort of social care policy around that, is that, of course, the two figures that become two key talking heads, as it were, arguing about this on live television back in the 1980s were Tony Fauci and then Kramer himself. Now, of course, Tony Fauci is in the news here again with the coronavirus. And Tony Fauci will say that at the time, what ACT UP was doing and what Kramer and his colleagues were trying to create was itself new for many people working in the sort of the drug and treatment side, that it nonetheless, it did change things for the better, and that within both healthcare policy, but also this idea of treatment for infectious disease, that groups like ACT UP did really create a dynamic that in the end helped a lot of people. And so I think that's where this idea of an activism around trying to advocate for care comes from. This gets picked up, of course, in lots of different groups. You could look at a women's health movement around cancer, but also then other groups around Alzheimer's, other groups around end-of-life care. There's a long list of ways that this also, I think, takes on different forms that aren't necessarily specific to different epidemics or viruses in that way. But through this course of action, then of course you get social activism that, for example, what ACT UP did in a number of instances were things like die-ins. Historical factoid around die-ins. Die-in actually this has been much debated among scholars of if you will, social movement politics, but it's believed that the first official die-ins actually started as a product of the early environmental movement in the late 60s, so 69 or so into the early 70s, but then the die-in becomes this method that's used to show the impact of some particular topic, and so this die-in becomes a crucial moment. This is a big one in San Francisco, where the idea is you obstruct traffic or you try to shut down daily life to draw attention to what is going on. The other thing that comes out of the virus, and I think that when we think about these areas going forward with COVID-19 and the coronavirus, is there was also a move to try and understand how can public attention be drawn to the scale of the deaths. And so one thing that was developed in the 1980s was something called the Names Project quilt, or sometimes just called the AIDS quilt. And it was a large arts and crafts style, American arts and crafts style memorial, in which you had 3 foot by 6 foot, and we'll get closer images in a bit, of different quilt pieces that were all joined together. And by the time it was finally fully displayed in 1996. So this is, I should say, Washington, D.C. in 1988. That's Central Park in New York in 1993. and that is Washington, D.C. in 1996. So by the time it's finally displayed for the last time in full in 1996, and so those who know D.C., that's the Capitol Mall, and so that's the Capitol building right there. You've all seen it in films, and it stretched all the way across the mall down to the Lincoln Memorial, and it's over 50,000 individual square or oblong rectangular pieces, as covering over 105,000 individuals. And the idea was in trying to capture the scale of what had happened with AIDS and HIV. And it sadly, or one thing to say about it is that it kind of got caught up in its own politics, and so it sort of disappeared. So those of us who are, again, of a certain age generation, I would say, who grew up around a lot of the politics around this will remember the quilt, but then it got caught up in a kind of like ownership dispute, and then it kind of got shelved and disappeared. Although a couple of years ago then, in 2014, I was able to see it. I was able to see the quilt in New York City. I was a scholar in residence at a museum in New York, and it happened to be on display in a place called Governor's Island, which is off off of Manhattan. You go to it by ferry, and this is a close-up image of what the quilt looks like in terms of a lot of the artistry that went into it. Sometimes it was just a simple name, that was all the people could do, and sometimes not even a last name, it was just a first name. There were a lot of people who were initially put on there like that, but the quilt itself became a real flashpoint for trying to remember those who died, and that's an aerial view of what that one section looked like that particular day. But I want to bring everyone's attention to, I think, an interesting historical political point on this, which is, so this was New York in 2014. This was the quilt on display in New York in Central Park in 1993. So 1993, Central Park, it was an enormous event, front page of the New York Times. By the time you get to 2014, it's on Governor's Island, and this is what the island looked like. Smaller portion, you had to get to it by ferry. And if I'm honest with you about it, and this I think is how sometimes these dynamics can change around different kinds of public perceptions of diseases, I will tell you it did feel like going to a plague island to see the quilt in that there in that way. It did feel like it had been, if you will, shunted off to the side or marginalized in a way that I think, had this been done in the 1990s, there would have been big public protests around it. What was striking about this was that how quickly it seemed to have been forgotten, how quickly the impact had seemed to have been forgotten about the quilt itself and its impact in trying to draw attention to the impact of AIDS. So in the last sort of chunk of time now, what I want to talk about, having gone through this history and kind of rehearsed it in lots of different ways, and I want to say very quickly that it's also, I think, important to say that while I've been talking about AIDS and talking about the HIV AIDS and sort of setting up what happened then, there's a lot of different periods of different kinds of infection, but certainly starting in the 1970s that you could draw on. You could look at Legionnaire's disease. You could look at any number of different diseases. SARS certainly has come up, MERS, Ebola, sort of speeding through the 70s, 80s, 90s, and 2000s that have had impacts, I think, on how disease, if you want to think about policy, has been decided. But for me, I think the HIV AIDS epidemic, but also then pandemic, as it results today, has always been important because it's still happening. And so we can think about, the thing about the AIDS pandemic is we're looking at 32, maybe 38 million. There's some back and forth about the numbers of people who've died from it. And so it's still happening. It hasn't changed, but what has changed has been, it has become a manageable, treatable virus, but one that remains terminal. And I think that what comes out of the social policy experience, but also just the political experience of HIV/AIDS, is the role that activism played in drawing attention to inequalities, but also marginalization of different communities that were being deeply impacted by the virus itself. So what happens now? Jumping ahead, what happens now? Well, I think a couple things. One is I can tell you that there will be a move to try and at some point memorialize something like the coronavirus. What that becomes, we don't know. We're too in the middle of it. We're too, I think, in the middle of trying to figure out what the coronavirus will become. It remains a novel virus. We're in the wilderness, as I was describing it earlier before the conversation started, or in speaking with my colleagues about it. However, one iconic image that has emerged so far, maybe it'll stay, maybe it won't, will be something like the face mask. And this was a collage of face masks that New York City created, of used face masks that were, instead of being disposed, were put together that way. Maybe, maybe not. I do know that local museums, Bristol Museum, particularly Bath Museum too, different museums in Bath, they are collecting objects and artifacts to sort of record this time as a human event. One memorial that I like to draw people's attention to, because I think it's very important, and I think it's important because it is an ongoing project, is a digital memorial. And digital memorials are a bit tricky because they do have a tendency to disappear, but nonetheless will remain more easily updated than fixed physical memorials. But this is a memorial of health and social care workers who had died from COVID-19, which is run by the Nursing Notes website. And it's a very clever, but also I think quite moving memorial, because what they've done, and you'll see at the bottom of the slide there, they've color-coded different individuals into different professions within the broader world of social care, and then located them using Google. It's a Google map. They've just located them across the UK as to where they've died. As it stands right now, 247 individuals have died. And the Nursing Notes website started this pretty quickly. And it's one of what will, I'm sure, be many that are simply trying to draw attention to different groups that have died as a result of COVID-19, but in particular, health and social care workers. As many of you will know, the frontline workers, particularly through the NHS, and those who work in the different care industries or care groups have been impacted, very deeply. Also too, and this is something when I first started talking about some of this material a few years ago, one of the groups I had flagged up actually were the Black Lives Matters protests, which are absolutely, around us today, both as a result of the protests and the activism around the death of George Floyd in Minneapolis. And I should point out, Minneapolis is a 35-minute drive where I'm sitting right now in Wisconsin. I lived in Minneapolis for many years. I lived in the neighborhood for many years that George Floyd was killed in. But that I think the Black Lives Matter protesters actually, that protest movement actually makes complete sense in terms of trying to understand political movements around awareness of death, and that the Black Lives Matter protests are absolutely a legacy of 1970s protests. But I actually would also say protests around HIV AIDS. It makes sense that you're trying to draw attention to marginalized groups and that there's a politics around it. But also too, I think that the mortality rates amongst Black, Asian, and minority ethnic communities, Black and brown communities of color, we can use a wide range of terms for this, that those are large and substantial, and that there will be a politics that comes out of it that I think fed into, quite frankly, the protests around George Floyd's death, but that going forward, I would expect to see many more protests of that model and of that kind of rage around disadvantaged communities dying from the coronavirus and complications from it for lots of different reasons. When we think about what happens, sometimes there are longer term outcomes we don't always foresee. So I'll give you a longer term outcome or impact of AIDS. So one of the things that happens, I think, as a result of the HIV AIDS epidemic in the United States is eventually then the recognition and legalization of same-sex marriage or marriage equality. And this is Jim Obergefell. And in 2015, Jim Obergefell, his case, Obergefell v. Hodges, was the legal case that made same-sex marriage legal across the United States. Here he is next to his husband, John Arthur, who had ALS, and John Arthur was dying when they were able to be married in the state of Maryland. And then they went home to the state they lived in, which was the state of Ohio, which did not recognize same-sex marriage. And so Jim Obergefell took the state of Ohio to court simply because he wanted his name put on the death certificate for John Arthur. He wanted his name listed as spouse. That's all he wanted. He just wanted to be listed as the spouse of John Arthur in the way that anybody else who was married was. And that ultimately was the case in a 5-4 decision that made same-sex marriage legal in the United States. And I don't think it actually was a coincidence that it actually had to do with something like a death certificate, something that had to be done around death and dying, in part because one of the situations that AIDS created was that it radically changed legal access to not only the dying in hospitals, as in who had the right to make legal decisions, but it also challenged who had the legal right to the deceased's remains. And this was one of the things that I think has kind of been forgotten about an impact of AIDS. So if you go back to the literature in the funeral industry in the 1990s, one of the things that funeral directors, particularly in the United States, and the laws are different in England, they're different in Europe, they're different in different parts of the country, but in the United States, the family members who were next of kin could make a legal claim to the deceased remains that would exclude an unmarried, unlegally recognized partner. In many cases, just added real insult to injury. And so your funeral directors in the literature trying to discuss, like, well, what do we do in terms of determining who has the legal right to the remains? And that set the stage for a legal challenge. So as far as legal changes that happen going forward with something like the coronavirus, we don't know. There'll be longer term changes, but they're hard to predict until, for example, 35 years later from now. One of the things to always keep in mind, I think that one change that comes out of the HIV AIDS epidemic is that, HIV remains a global pandemic, and a global pandemic particularly affecting different parts of the world that are more easily forgotten. And so there's been huge campaigns over the years around, in particular, sub-Saharan Africa. But I think that in the West, we tend to forget that something like HIV remains an enormous epidemic around the world. And that if I were honest about it, I certainly think that coronavirus, both as a virus itself, as you can see from a daily basis, is sweeping around the globe, runs the risk of being forgotten about in the developing world. And that I think in terms of policymaking, but also in terms of care, that becomes a huge issue, and one that I think AIDS actually has already demonstrated what happens, but also how it can be productively dealt with when organizations, different governments choose to not think about what's going on in different parts of the world around prevention, but prevention and how those things play out. I also think going forward that in terms of, and this will be one of I think the key policy areas, I'm going to predict, and predictions are a tricky thing, that we're going to see a resurgence of let's say over 65 age group, particularly in the UK, of activism around death and dying. There's already groups there that are trying to push around end of life choices and care directives, and certainly my colleague Kate Woodthorpe has an enormous amount of work around trying to encourage or inculcate conversations more around end of life decision making. But I actually think we're going to see a stronger commitment to individuals choosing to, for example, die at home, if they know that the choice of dying at home or dying at the hospital means, if I go into a hospital to die, I won't be able to see any of my family members. And or I think possibly there's going to be a rethinking of access to the dying, access to individuals who have the coronavirus, in part as a rethinking goes on around what family members can do to have access to the dying or to the deceased. So, for example, there are protocols in the books that talk about if someone has an immunocompromised condition, or they have some kind of potentially contagious decision, it is entirely possible, for example, family members to put on, or next of kin to put on PPE to see an individual. But as we headed into the coronavirus, it became clear that there just wasn't enough at the time equipment to go around. And so that's an ongoing issue, but there's nothing necessarily from a technical standpoint from preventing families from getting in there to see someone who's dying. How that goes forward, I'm not sure, but I think this is going to become an issue where family members simply say, well, it's a choices between we seeing them and we not seeing them. Either we're going to put on the equipment or they're going to die at home. I also think there's going to be an issue around healthcare costs. It's going to have to be thought through. And this is both access to care as well as who covers the care. In the UK, we've got the NHS, and I'm very happy to be someone who lives in the UK actually as a dual American-British citizen and who has the NHS. This is going to be a bigger issue, I think, particularly in the United States going forward. And I'll give you one anecdote about that. I mentioned I had come home to help my parents when my father was hospitalized in December and then had rehabilitation in January. And his hospitalization was for a massive cardiac arrest. He had a anoxic brain injury as a result of lack of oxygen. He's more or less fine, so it all worked out in the end. But we didn't know that, and so he was for 2 weeks in an ICU and then another week in the hospital itself before going to transitional care. And the hospitalization bill for his care was in US dollars, $420,525.25. One more time, $420,525.25. And I know all this because he was sent the billing information. It was accessible online. I could download it into Excel, which I did. And because my parents both are over 65, they are covered by what's called the United States government's Medicare program, which is a nationalized national healthcare program. So they ended up only paying out of that 420,000, about 1,300 US dollars, which for some families would be a stretch, but they could manage it. This is my way of saying that the healthcare bills are going to start rolling out, and we've already started to see some reporting on this around COVID-19 care, which if you were hospitalized, oftentimes is the most intensive kind of care, particularly in an ICU, particularly with a ventilator, which is what my father was on. And that there's already one case that came out for a gentleman who was in his 70s in, I think it was in Washington State, I think it was Seattle, where his bill was over $1 million US dollars, which I completely was not shocked by. He as well was receiving Medicare or the federal subsidized care because of his age. So he'll end up paying, several thousand, let's say $6,000, which again would be a lot for a lot of people. But I think one thing that might come out of the COVID-19 experience in the United States, maybe I could be naive on this, is you could see a move towards a more nationalized healthcare plan, simply because the bills over time, they won't be paid, and it will just become, it won't be possible to pay them. That people are going to be faced with hundreds of thousands of dollars in bills. Furthermore, after an individual dies, families will oftentimes be sent the bill as a next of kin to take care of it as that goes. So I think healthcare is going to have to be taken care of. I also think healthcare costs are going to have to be adjusted, and many people have already raised this in terms of access to things like treatment, whether it's different drugs that could be possible treatments for something like the coronavirus. This came out of AIDS, or also then treatments to things like vaccines, which then leads me to, I think one of the key final points around this is I think if HIV is taught us anything in terms of the science of medicine, but also just in terms of the hope of policymakers, is we should always be prepared for there to be no vaccine for the coronavirus. And that I know that, again, the viruses are very different, squirrels and rabbits, but that I think that the HIV experience that is ongoing, I think is, if it's taught us anything, is that the science is such that the promise of vaccines does not always come to fruition, and that it may become necessary to rethink different governmental policy programs around there not being a vaccine, but more of a management in long term over years. But also to keep in mind that something like testing takes time even before you get to vaccines. So for example, we've forgotten that it took 3 years to develop a reliable test for HIV, like 3 years. So you imagine 3 years from now in terms of that kind of sort of protocols. Now, groups like ACT UP and other activist organizations, they helped different testing groups, but also then different government organizations move faster in developing these different treatments, but also too, they need to be safe. And this is going to be one of the issues going forward, which is, is this vaccine that we want to use going to work, or is it going to, in fact, kill people in its use? And there are instances of that. This happened in polio before a vaccine was withdrawn because it was introduced, too soon. And that would only create further problems with, individuals already prone to reject vaccinations. I think one of the last things I want to sort of leave everyone, I'm just going to close with this, it's a quote from Michael Spector, who has written for years around, I think, infectious disease and pandemics and epidemics, and wrote some of the, I think, really interesting work in around Ebola, but also HIV AIDS. And Spector wrote this great piece in the New Yorker that I read on the plane flying here from March 17th. And I think what he says is, the bigger question is whether we will learn from the fact that this pandemic will kill many more people than it had to. I'd like to think we would, but if the past is any guide, this pandemic will end up with a bunch of new commissions and ominous reports. And as soon as they are printed, they will be forgotten. And I think going forward, this remains one of the key, if not fundamental and urgent social policy challenges, but also challenges for those of us who work in the history and bioethics, science and technology studies, any number of fields around infectious disease, but also death and dying, is that there's always the challenge that once the report is written, once the commission is done, whatever it is looking at is simply forgotten. And in that, the impulse, I think, in terms of a broader social understanding or a broader societal, if you will, forgetting of something like the coronavirus, which in some cases I think some people have said is already taking place, which in the US, I think you could point to different states where that is the situation. I think that's going to be a real challenge. And I think that the one thing I take away from studying the history of HIV AIDS is that there will be changes that are made as a result of different groups who are trying to change policy around healthcare and policy around access to care, that many of those will be taken on board. Many will not be taken on board, but that whole process of how that ever happened will in large part be forgotten, and that the disease itself always runs the risk of being forgotten. And I think that right now represents a real moment with pandemics and deal with infectious disease outbreaks, because if Michael Spector will point anything out to us, what is going on right now in terms of a coronavirus pandemic was largely predicted for years. And as a person, as an academic myself, who worked on pandemic response plans for the UK government, more on the fatality side, mass fatality side, or the death side, I can tell you that those plans were not followed. And it will be an ongoing question as to why. Okay, I will leave it there. Thank you very much. I'll now hand everything back over to Sarah, and I'm happy to field any questions about this, and happy to field any questions anyone has, both around the talk itself, but also around COVID-19 that way. Thank you.
Okay, thanks, John. You can hear me, can you?
I can hear you, yeah.
Just
hit me with all your questions.
So we've had some come in. One from Kerry Walden, who said, as you said, we still don't have a cure for AIDS, and as you finished with, we may not get a cure for coronavirus. Do you think that it will become manageable in the way that AIDS is, or is more than it was?
Yeah, sure. No, I know. Yeah, that's a great question. And what is manageable? Yeah, absolutely. I mean, and again, this is going to be before all my medical science colleagues jump in on me and be like, don't compare, because we aren't talking about different viruses. I want to be clear about that. So is it manageable? Sure, of course it's manageable. Any infectious disease, that's a big statement. Any infectious disease is manageable. Infectious diseases are manageable. What we're going to have here is a question, I think, about access to treatments, access to management, and quite frankly, who's going to pay for it? and how that is done globally. And in trying to create, for example, if we get to this point, a global vaccination campaign for coronavirus. One of the unintended consequences of the coronavirus, the rush to work in coronavirus, has been the decline in immunizations for a whole long list of other diseases across the developing world, because everyone's attention has been diverted to the coronavirus. And so that's going to have impacts. I also think that there's a whole long list of reasons where, the secondary deaths will always be an issue, where as we divert attention towards something like coronavirus or any kind of infectious disease, you have individuals who are dying from other diseases. So for example, cancer, where it might have been treatable. And so that's going to become an issue. So is it manageable? Is it treatable? Yes. Are there models for it? Absolutely. And I think that from the political standpoint, the issue is going to be how that's explained to the public. And I think that is going to be that's where policy and practice really meet, because that's going to have to be clearly articulated to the public in trying to create effectively a generational change in how everyday life is lived, if it gets to that. Yeah.
Okay. We've got another question from Sally Rawdon, who asks how you understand or analyse the lack of public memorialisation around corona deaths so far in the UK and US. So she sort of mentions the lack of attention in government briefings and statements, things like that.
That's a great question around, the question's already been raised, like, will there be a memorial to the people who died from COVID-19? By which I would just say there's not actually any national memorials. There's very few national memorials. You can find them sporadically, but to something like the 1918 flu influenza. So there's a real politics around memorialization. So I think one thing that you can say about most governments is that they are loath to point to how many people are dead, but also are dying or dead from a largely preventable situation. And the way that I equate in some cases the coronavirus deaths right now with another public health policy failure, which comes up periodically, which are heat wave deaths, because heat wave deaths can always be understood as a kind of public health death that is largely preventable. That it is, and during massive heat waves, we'll see these waves of deaths that take place, but they're preventable because largely you can just keep the bodies, keep people in a cooler state, and that is again always usually an access issue. So going forward, how does the memorialization work around that? I think largely there could be attempts by different governments to do it, but if I'm honest with you, Sally, I think it's largely going to come down to families, and there's already a bereaved families group in the UK that created an activist platform to draw attention to the people who died, and I think that along the lines of a kind of ACT UP, that there's going to be that sort of push for recognition from government, and that there's going to have to be that kind of activist model that does it. I honestly don't think that we'll see it come from the government side. I don't.
Okay, so got another question from Elizabeth Harrop, who says she's just curious about clarifying key differences with HIV and COVID-19. Marginalised communities with COVID-19 globally are women and children. Women make up the majority of informal workers in developing countries, so affected by lockdown and lack of access to social protection. And not all of it. Sorry, I've just scrolled too fast. Not all are victims of the disease, but are also victims of response measures, which is different to HIV, because it's not just infection and death itself, which affects the marginalised.
Yeah, no, and I think, no, thank you, Elizabeth. It's a key point. Again, I want to make it clear that there are differences. There are crucial differences, both in terms of care, in terms of government response, in terms of how the communities are dealt with and responded to, and how something like a lockdown impacts along gender lines as well as I think labor lines, work lines. Absolutely. I mean, these are different political dynamics, and I think that they will play out in different political ways, but also too around the world, how this virus impacts already marginalized groups is crucial. So I want to be clear about that we will see different. I think we will see different kinds of activism, I think, grow out of the different experiences of it. I think that's what I'm trying to get at. And that it will change the nature of different kinds of activism that way, but that different countries need to be thought of in different ways. Absolutely. And that I think is crucial too. Yeah. I mean, one quick anecdote about that. So one of the key, so after, the death of, recently the death of Mr. Kramer and everyone around ACT UP and the gay men's health crisis, there was actually a lot of celebration of his work, but there are a lot of people who came forward and said, Kramer was, he was kind of he wasn't really a leader of anything like ACT UP. There are a lot of different groups of women and individuals who were African American or Latinx, and there's a lot of different people here. But the thing that Kramer could do would be that he could get in to talk with someone like Tony Fauci, in part because they recognized him as a white man with a Ivy League education. So he was like, oh, I recognize him that way. So that there was this way that, the politics of how ACT UP actually worked, or sort of the communities they covered, got kind of blurred in a way that wasn't actually correct. And so I think that when we think about this, as we begin to, I think, unfairly homogenize different activist groups and what they do, that those are always the specifics we have to be paying attention to. Absolutely. That was a bit of a tangent, but I think it's important to point out that way.
I'm just aware of time, and I think we've actually run out right now.
I can take a couple more questions, but it's up to you guys if people want to.
I mean, I'm fine if you are. So
we're good then, yeah.
Okay, so another question from Caroline Pretty. She said she would be interested in your thoughts on the parallels between HIV/AIDS and COVID-19 in terms of fears about the potential risks from dead bodies and how this has led to restrictions on how people can be with and care for their dead.
Yeah, thank you, Caroline. I totally didn't say that. So thank you for that great question. Yeah, so one thing that comes out of the AIDS epidemic very quickly is there was a profound fear around in the funeral industry in particular, in a lot of different ways, but I know the funeral industry best, around the handling of individuals who died from HIV/AIDS, and that profound fear was that the dead body was contagious, that it was a carrier of the HIV virus, and that there were actually restrictions in place for a long time that said, do not let family members touch the deceased from HIV. Now that turned out not to be the case, that with proper care of the dead, which in many cases just meant proper refrigeration, the virus died. That was HIV. And so it quickly became clear, but it took many years. When I say quickly, I'm talking a number of years to actually get to that point where it was clear that the body was, the virus was more or less inert, that it was okay to touch the body. I would say that I think that with coronavirus right now, that the concerns around being able to touch the dead, again, coronavirus is a respiratory disease, and I want to be very clear that it has a different kind of it's a different virus that way, but that it may end up, I think, in the long run, so a number of years from now, it may turn out that the prohibitions against touching the deceased or being around the deceased may turn out to have been largely unfounded, but we don't know. We need more research around that. As of right now, I think, based on what the CDC has said and other European partners have said, that with proper handling of the dead, that there doesn't necessarily need to be a restriction on, for example, family members being able to touch the deceased if they want to. However, there's going to need to be more research, and I think that will be one of the great, going forward, because again, we're in the middle of all this, we'll rethink this period, and we'll see what was going on. But it's interesting to note that when you get thrown into these pandemic situations, those expectations change. So I think that we'll see those rules change, but it's going to take time.
Okay, and then one final question.
Please.
From Emma Rich. What kind of commonalities and differences are there between public communication of responses to AIDS or COVID-19 in terms of trust and expertise? It's been argued that the speed of politics exceeds the science in the case of COVID-19, and it's possibly undermined the trust in science.
Yeah, it's a great question. That's okay. I mean, I think that I was just thinking about the speed of politics point, because I was actually sort of thinking about Virilio's writing about speed and acceleration of politics in the 1970s, right? He's writing about this. And I think that there is a real issue. I know the UK government and I know the US government best. And I think, just a real, from a policy standpoint, making of promises that are just not possible, like things that aren't there. But also too, I'll tell you right now that one of the organizations, but websites I check every day, and especially over the weekends, is the Retraction Watch website, which covers retractions in the academic literature across all fields. And there's and this has been flagged up now. There's a real issue around a rush to publish research around coronavirus, which I think everyone understands, but then a lot of it just being retracted, or a lot of it being done too quickly. But also too, I think there needs to be better, for those of us who work in science communication, there needs to be a better communication and explanation to the public, but also policymakers, quite frankly, in understanding, the differences between, a pre-press, non-peer-reviewed article, a peer-reviewed article, but then also a peer-reviewed article that may have to be corrected, or an article that has to be retracted, and why those reasons are. But that these dynamics that go into, again, a sort of like the human hope of technology to solve the problems, that they really feed into in oversimplifying of the complexities of what we're talking about. And so once you get the policymakers, I think they're always going to be looking for, not always, many of them, not all of them, will be looking for the easiest soundbite or the easiest, 2-word, 3-word explanation. And that's just not, I don't think that's possible going forward. And if we take the hypothetical, for example, that if we take the hypothetical that a vaccine is not possible, just a hypothetical, I mean, the research is ongoing, we don't know. How that is explained to the public, I think, is going to be crucial, right? And how that is understood is going to be crucial. Because I think that if we learn anything, I think, from the early 1990s around HIV was, and I remember all this, it was the publishing of all the hopes around the research around this vaccine. And then it just became clear it was just never going to happen. So I think that there's a real issue with that. And I think that there's going to be those of us who work in social policy and digital communication and social media platforms, that's going to be a real issue too. But also too, like, man, I think we should all get ready for, I don't think we've begun to see really the full, if you will, the full horizon yet, even of conspiracy theories, of any number of things. And that's only, I think a lot of it's only in some ways going to get worse. So, on an individual level, I think we need to communicate these points as, to the best of our abilities.
Okay, so I think that's probably our lot for today.
That's fine. Thank you.
Yep.
I've said more than enough. Thank you for being in today. This is, it was older research, but I think ongoing research going into this. And this is one of those areas I'm interested in trying to tackle. And I think that there's always a danger in trying to overly interpret the current events through the lens of previous events. However, I do think that the past events, something like HIV, can offer us a way of thinking what could happen in the future. And that I think is valuable.
Okay, so as as John said, thank you everyone for joining us, and thank you to John for all that has now given us to think about. As we said at the beginning, the session will be available as a podcast and online video via the IPR website. And if you enjoyed today's webinar, you might be interested in another one taking place on the 29th of June, where colleagues from CDAS will be discussing end-of-life care and bereavement support during COVID-19. And you can find out information about that on both the CDAS and the IPR website.
A quick plug for Monday's event. Monday, we have Dr. Chow Fang, Dr. Joe Wilson, and Dr. Paula Smith coming in, and it's going to be very good. And I think that they'll have different perspectives. Chow will be talking about what's been going on in China. CDAS does a lot of work across China. Actually, I was supposed to be in Shanghai right now. So in some ways, I'm not, so I was able to do this. Joe Wilson is a palliative care nurse working for the NHS in London and has been on the front line. And Paula Smith is in our Department of Psychology and works around bereavement and how families approach it. So it's going to be very good. And I would highly recommend anyone who's watching still, check that one out.
Okay, brilliant. Well, thank you everyone. And
thank you everyone.
Hopefully see you all Monday.
Yeah.